In this lecture, we will be discussing glucose regulation. Of course, the best known exemplar of glucose regulation imbalance is diabetes mellitus. I'd like to stress that it is not the only condition that results in imbalance of glucose regulation, but if you can understand diabetes mellitus, its effects, and its treatments, you can apply this knowledge to understand glucose imbalances caused by other reasons. Because of this, we will focus on understanding diabetes mellitus types 1 and 2 in this lesson. By the way, the word diabetes itself comes from the Greek word for go through, or siphon, as in to siphon or pass through a large amount of urine. So diabetes itself as a word is used to describe a condition in which a person urinates an abnormally large amount. As you'll see in the slides below, polyuria is one of the classic symptoms of hyperglycemia. But you will also see the word diabetes used for another condition that has nothing to do with high blood sugar, diabetes insipidus. Diabetes insipidus is caused by a hormone dysregulation or a dysfunction of the kidneys and is marked by increased urination. The word mellitus in diabetes mellitus comes from the Greek for sweet, so diabetes mellitus refers to passing a large amount of sweet urine. This is because in hyperglycemia, an excess amount of sugar is passed through the urine. Once upon a time, physicians taste tested urine for sweetness to detect diabetes mellitus. Now we have other methods for diagnosing diabetes. Thanks, modern medicine. Here we have a picture of the pancreas. The pancreas is an endocrine gland responsible for glucose regulation in the body. Pancreatic hormones are produced by alpha cells, beta cells, and delta cells. Alpha cells are responsible for producing glucagon in response to low blood sugar. Glucagon stimulates the liver to break down glycogen and fats in order to raise blood glucose levels. Beta cells secrete insulin. Insulin allows the sugar in our blood to cross cell membranes so that our cells can use the sugar, or glucose, for energy. The delta cells produce somatostatin, a regulating hormone for both glucagon and insulin. So you see, the pancreas is responsible for a tight dance of hormones that keeps our blood sugar levels in just the right range to meet the needs of our brain, muscles, and other tissues. Diabetes is a group of chronic disorders resulting in hyperglycemia. Type 1 diabetes is characterized by a total deficit of circulating insulin due to the destruction of the beta cells, so there is no insulin being produced by the body. Type 2 diabetes mellitus is characterized by resistance of the body's cells to the insulin produced by the beta cells, and eventually a decrease in the production of insulin. This is the simplest way to describe the differences between types 1 and 2, though as you'll see, there's more to it. In a normally functioning individual, insulin levels rise and peak within minutes after meals. Insulin is a very important hormone for the use and storage of energy in our body. It facilitates movement of glucose into the muscle cells, stimulates storage of glucose as glycogen, inhibits gluconeogenesis from amino and fatty acids, and increases fat deposits and protein synthesis. You can think of insulin as a key and cell receptors as doors that insulin opens. If there are not enough keys to open the doors, or if the locks on the doors are broken and won't accept the keys, then the glucose cannot move out of the bloodstream into the cells. This causes hyperglycemia, or high blood sugar. Understanding diabetes mellitus is actually pretty simple overall. Imagine all of that glucose as table sugar running through the tiny vessels of the body. You are destroying the blood vessels with sugar. Most of the complications of diabetes are caused by this damage, and likewise, our treatment of diabetes mellitus focuses on lowering blood sugar. Type 1 diabetes used to be known as juvenile diabetes or insulin-dependent diabetes. But as you'll see, we have more and more cases of type 2 diabetes appearing in children, and also many type 2 diabetics use insulin. So these names are misleading for type 1 diabetes and are no longer used. So we use type 1 to refer to people with diabetes mellitus because of an autoimmune destruction of the pancreatic islet cells. So the cells that create insulin are destroyed, and no endogenous insulin is being produced by the body. Endogenous, so that's something that is created by the body. It typically occurs in childhood or adolescence, and it has a rapid onset, and it is idiopathic, which means that the cause is unknown. But there are risk factors that will be discussed later in this presentation. There is a genetic predisposition to type 1 diabetes, and this plus exposure to a virus may contribute to development of type 1 diabetes mellitus. And about 5 to 10% cases of diabetes mellitus are type 1. And people with type 1 diabetes are at risk for developing a diabetic complication called ketoacidosis due to their complete lack of insulin. In type 2 diabetes, some insulin is still produced by the body. However, it is insufficient to meet the needs of the body, and it is poorly utilized by the tissues. 3 metabolic abnormalities are associated with diabetes mellitus type 2. 1 is impaired insulin secretion. 2 is insulin resistance, which is marked by an inadequate number of receptor sites and unresponsive receptor sites. And 3, excess glucose production by the liver, also known as glycogenolysis. Onset of type 2 diabetes mellitus is usually gradual and generally progresses through stages. In early stages of insulin resistance, the body will produce larger amounts of insulin to overcome the unresponsive receptors. This leads to exhaustion of the pancreas and a decrease in insulin production. If we continue the analogy of locks and keys, we can think of the keys breaking in the locks because the locks are broken, and we have to keep using new keys in the locks until we find one that finally opens the lock. In the meantime, we have to go through many keys just to open up one lock. And so there's a key maker, which is the pancreas, which keeps creating keys, more and more of them, just to open up the dysfunctional locks. Well, eventually the key maker is going to get really tired of producing all these extra keys. And so the key maker is going to kind of give up, get tired, and produce fewer keys. And this is the point at which the body is producing less insulin because it's just so tired. Now, there are other problems that occur with diabetes type 2. The alpha cells of the pancreas are going to start producing more glucagon in response to all of this imbalance. And this leads to excess glucose production by the liver, which is going to further increase the level of blood sugar. So we have 2 ways that blood sugar are being raised now, both because the insulin isn't working in the receptors and because the liver is now creating more glucose on top of that. Please note that there is also a 4th metabolic abnormality besides the 3 that are on the slide, and this is the inappropriate production of hormones and cell signaling proteins called adipokines by adipose tissue, including leptin and adiponectin. This results in altered glucose and fat metabolism. And this is just another way in which there is an imbalance of sugar in the body in diabetes type 2. Here is an image depicting the pathophysiological process of diabetes type 2 in the initial stages. In this example, the pancreas produces adequate amounts of insulin, but the body's cells are resistant to the effects of the insulin. Therefore, the insulin is not accessed by the cells, causing hyperglycemia. As this chronic condition progresses, the individual will exhibit signs and complications of hyperglycemia, and the strain on the pancreas will eventually lead to decreased insulin production. And this is why it's so important for individuals with diabetes type 2 to control their diabetes in its early stages, because if they can control their high blood sugar levels when they are still in the early stages of diabetes type 2, they can save a lot of the function of their pancreas, and they might not need to use more intense forms of therapy in the future. In fact, they may even be able to control their diabetes type 2 through diet and exercise alone and keep their blood sugar levels at healthy levels without needing any kind of pharmacological treatment. But that's only if they control their diabetes early on, because once that pancreatic function is lost, once the pancreas is already tired and its cells have already started to be destroyed, then we can't go back. And the patient might, at that point, be dependent on insulin. Also worth mentioning is gestational diabetes. Gestational diabetes occurs when the hormones from the placenta block the action of the mother's insulin, causing insulin resistance. Gestational diabetes usually resolves when the baby is born, but increases the risk of the woman developing type 2 diabetes later on. Next, we will discuss assessment of diabetes mellitus type 1 and type 2. First, we will discuss the risk factors of type 1 diabetes. Anyone with a parent or siblings with type 1 diabetes has an increased risk of developing the condition. The presence of certain genes indicates an increased risk of developing type 1. Viral infections, such as mumps or rubella, are thought to be an environmental trigger to the autoimmune destruction of the islet beta cells. In some cases, usually through a clinical trial, genetic testing can be done to determine if a child who has a family history of type 1 diabetes is at increased risk of developing the condition. Research suggests that vitamin D may protect against type 1 diabetes. However, early intake of cow's milk, a common source of vitamin D, has been linked to an increased risk of type 1 diabetes. Omega-3 fatty acids may offer some protection against type 1, while drinking water that contains nitrates or eating cured meats may increase the risk. Additionally, the timing of the introduction of cereal into a baby's diet may affect their risk of type 1. One clinical trial found that between ages 3 and 7 months appears to be the optimal time for introducing cereal. The exact cause of type 1 diabetes is not completely understood, but there is an ongoing research to find treatments or cures. Type 2 diabetes has several risk factors, including genetic predisposition, age, obesity, inactivity, race or ethnicity, history of gestational diabetes, hypertension, lipid disorders, polycystic ovarian syndrome, vascular disease, and metabolic syndrome. Metabolic syndrome is a particularly prevalent predictor of developing type 2 diabetes and will be discussed in the next few slides. Type 2 diabetes is more prevalent in African Americans, Asian Americans, Hispanics, Native Hawaiians, and Pacific Islanders, and Native Americans. About 1 in 3 adults has metabolic syndrome. So what is metabolic syndrome? It is a condition characterized by increased glucose levels, increased triglyceride levels, decreased levels of HDLs, and hypertension. Presence of at least 3 of the 5 components is considered metabolic syndrome. Also associated with metabolic syndrome is abnormal fibrinolysis, or breakdown of blood clots. So if you think that you have a alteration of breakdown of blood clots, it means you're going to have more blood clots and all of the problems that can come from blood clots, including stroke, right, and myocardial infarction. All of the characteristics of metabolic syndrome increase the person's risk for developing diabetes type 2 and cardiovascular disease. I do want to add that the book references the wrong table for metabolic syndrome. Instead of table 4110, see table 4011 on page 890 for more information about metabolic syndrome. I would like to add that metabolic syndrome itself is not considered a disease, but there are risk factors that are considered to lead to this syndrome, which can then lead to other problems like diabetes and cardiovascular disease. These are central obesity, sedentary lifestyle, family history, gestational diabetes, increased age, and being Native American, Hispanic, or African American, and polycystic ovarian syndrome. While age is a common risk factor for diabetes type 2, usually occurring in individuals over the age of 45, there is a growing incidence of type 2 diabetes in children and adolescents related to increased rates of childhood obesity in the United States. There is a video link here, and you can access this by opening the slides, which I will post. And this video was made over 10 years ago, but it remains relevant, so I'd like you to watch it. It's not too long. And I'm also including in the notes section a resource by the Centers for Disease Control about type 2 diabetes in children. Now we will talk about the clinical manifestations of type 1 diabetes. The clinical manifestations of type 1 diabetes are essentially manifestations of hyperglycemia, and they include the following: recent weight loss, which is caused by a lack of cellular access to the glucose, fatigue, which is caused by a lack of cellular access to glucose, and the three polys: polyuria, polydipsia, and polyphagia. In polyuria, increased hyperosmolality pulls fluid into the vascular system. This causes increased blood volume and causes the kidneys to release more urine. So kind of the way water follows salt, well, water also follows sugar, and if there's a high amount of sugar in the blood, you're going to have more water moving into the blood and moving out through the kidneys. Now, because of this increased urinary output, we have dehydration and then increased thirst. And so the individual will drink more, so polydipsia. And also, because of the lack of cellular access to glucose, the individual is going to feel hungry. Since their body doesn't have the energy it needs, the body thinks that it needs to eat more. And this is what polyphagia is. Also, a clinical manifestation of type 1 diabetes is glycosuria, which is excess glucose being excreted by the kidneys through the urine. The clinical manifestations of type 2 diabetes are more subtle and often appear gradually. As a result, diagnosis may be delayed for some individuals, which means that some people will experience complications of diabetes before they are formally diagnosed. For example, non-healing wounds and paresthesia are common complications of diabetes, but may already be present when the client is diagnosed. And this makes sense if you consider the fact that the body is still producing some insulin in type 2 diabetes, especially in the earlier stages. So the clinical manifestations might not be as sudden and as intense as they are for type 1 diabetes. Regarding paresthesia, remember that can present in a number of different ways, including numbness, tingling, and/or a burning sensation. And that's what we're looking for when we ask our patients about numbness and tingling in their feet, right, when we do an assessment. Also, the acanthosis nigricans is a darkening of the skin, usually in the folds of the body. And the vaginal infections are caused by the increased amount of sugar, which is not just energy for us, right? It's also energy for microorganisms. So there are actually several studies which are used to diagnose diabetes mellitus. A diagnosis of diabetes can be established with signs of hyperglycemia along with a plasma glucose concentration greater than 200 mg/dL, which is taken randomly at any time. And remember, the signs of hyperglycemia include polyphagia, polydipsia, polyuria, and unexplained weight loss. Another study which is used is fasting plasma glucose. And this blood test is taken when an individual has not taken any calories in 8 hours. And if the result is equal to or over 126, that is considered diabetes mellitus. And if the result is between 100 and 125, the individual is considered to have impaired fasting glucose, known as pre-diabetes. The oral glucose tolerance test is another test that is used to diagnose diabetes mellitus. With this test, an individual is given 75 grams of concentrated glucose. Their blood sugar levels should return to normal within 2 to 3 hours. And if the result of taking their plasma glucose levels 2 hours later after taking the oral glucose, if they're over 200, then this person is considered to have diabetes mellitus. I'd like to note that the 3 previous tests that we just discussed all reflect the individual's blood glucose levels at the time that the test is taken. So that is their present blood glucose level. The hemoglobin A1C, which is another kind of blood test, is unique in that it allows us to see what the person's average blood glucose level has been over the last 3 months. This test, it shows the amount of glucose attached to a red blood cell during the cell's lifespan. A level of 6.5% or above indicates diabetes, so notice that hemoglobin A1C results are given in percentages. Although hemoglobin A1C results are given in percentages, they can be converted to average blood glucose levels in mg/dl. So 6% would be 135 as an average, 7% would be 170 as an average, etc. And you see at the top there, 12% means that the person's average blood glucose level has been 345. This test is also used for monitoring blood glucose control after initial diagnosis. 7% or below is considered good control of blood glucose in an individual that has been diagnosed with diabetes mellitus. Let's talk briefly here about prediabetes. Prediabetes is a stage between normal glucose homeostasis and diabetes mellitus. It can be defined in 2 ways. The first is impaired glucose tolerance, or IGT, which is diagnosed if the oral glucose tolerance test results are between 140 and 190. And 2, impaired fasting glucose, or IFG, which is diagnosed if the fasting blood glucose levels are 100 to 125. Now, an individual with prediabetes can have prediabetes if they have one or both of these 2 impairments. Prediabetic individuals are at increased risk for developing type 2 diabetes later on, and usually there are no symptoms, but damage can be happening to the cardiovascular system and other systems of the body. To prevent development of full type 2 diabetes, these individuals should engage in prevention measures such as lifestyle changes. Also, they should regularly check their A1C and monitor for diabetes symptoms. We'll talk now about glucose monitors. These are used to monitor diabetic management. There are several types of monitors for home use or for use in a healthcare facility. The frequency and timing of monitoring is individualized to client needs. Glucose monitoring is considered a kind of point of care test because results are available at the bedside or the point of care. Point of care blood glucose values are often lower than levels reported by the lab. This is because point of care glucose monitors use whole blood, whereas lab tests use plasma, which exhibits higher glucose values. So most current monitors are calibrated to provide the equivalent of a plasma result so that point-of-care results can be compared with lab values. Please also know about continuous blood glucose monitoring, which is described on page 1135 of the Lewis et al. Text. Blood glucose monitors are effective and accurate for monitoring diabetes mellitus management. However, there are several factors that can affect blood glucose results. Because of this, patient education and education of caregivers on correct use and care of the monitors and equipment is a nursing priority, particularly for the client who is managing their diabetes at home. Also, please be aware that if results are exceptionally high or low, facility protocol may require a blood draw. Things to consider are user error, inadequate blood sample, improperly stored or outdated test strips or control solution, an uncalibrated meter, and a soiled meter. So, recommendations on how often a patient should be self-monitoring their blood glucose will vary from individual to individual, and it depends largely on how likely the person is to be hypoglycemic, how likely it is for their blood sugar levels to drop. People who are on insulin have the highest risk for hypoglycemia, especially people who are taking several doses of insulin a day. So people who are on insulin will be taking their blood sugar multiple times a day, usually before meals and at bedtime, and occasionally they'll be taking their blood sugar levels after meals, and it should be at least 2 hours after meals if they do so. They will also be taking their blood glucose levels before they exercise, because our blood sugar can drop when we exercise because our muscles are eating up all of that glucose. The individual will also be taking their blood glucose level if they're having any symptoms of hypoglycemia at any time. And once they've treated for their hypoglycemia by taking, say, a glass of orange juice, they'll continue to take their blood glucose levels until those levels have returned to normal, to make sure that they do return to normal. And if the person is only taking a single dose of basal insulin a day, they may not take readings as often as patients on multiple insulin injections or who are using a pump. Now, for patients who are not on insulin, the patient may test once or twice daily or a few times a week, depending on what treatment they are on for their diabetes mellitus and what their response has been. How stable are they? Now, if the patient is on an anti-diabetic agent which can cause hypoglycemia, which is most of them, the patient should at least be testing once daily or twice daily, because they are at a risk for hypoglycemia. Now, if they are on an agent which does not by itself cause hypoglycemia, or if they are controlling their diabetes with diet and exercise alone, the patient should at least be taking their blood glucose several times a week, both as a way to provide feedback to the patient and encourage their active participation in self-management, and as a method of providing data on the effectiveness of their control. Regardless of their normal self-monitoring blood glucose routine, all patients should be taking their glucose levels more often when they are ill, because illness causes changes in blood glucose levels. Typically, we see blood glucose levels skyrocket when someone is sick because of the stress that the body is placed under, and their response to their typical medications may also change. I want to stress that self-monitoring of blood glucose is a very important part of diabetes mellitus self-management. It is the cornerstone of self-management. And so it's important to be sitting down with our patients and asking them how often they are monitoring their blood glucose, and also how are they monitoring their blood glucose, and making sure that they're doing it correctly. Now, some people do not take their blood glucose levels as often as they should be, and occasionally you will have to get in contact with the provider who is managing the patient's diabetes with them and finding out what their recommendations were to the patient to make sure that how often the patient thinks they should be monitoring their blood glucose matches with how often they were recommended to take it.